What we want to focus on is the tips and tricks, and Stefan just mentioned some of these things like caps, lifting device, injection solutions, and we'd like to start our presentation on that. And first topic would be attachment hoods, and we already have some questions from the web, which we want to focus on. On that slide, you see a couple of these attachment hoods which are available, and we made a short video. This is one of our ESD standard attachment hoods with a 4 mm distant cap. If you put it dry on the endoscope, it's fixed pretty good. You don't have to take a tape necessarily. I placed the outer rim of the attachment hood right at the border of the visual field. This is another attachment hood which we use for ESD. It's from Fujifilm, an SD hood with a tapered tip. If you put it dry on the endoscope, it'll be fixed pretty good. You don't necessarily need a tape. And you have to take a look that you have the guidance for the working channel at the right place. Best is if you do it with an instrument in place. If you just need a soft cap for the tip of your endoscope, you can rip off the flexible part of this cap and just use this very soft flexible part on the tip of your endoscope. Here you can see the very flexible soft cap now. There's no traumatization of the tissue. This is about caps, and I think Stefan just showed the soft cap and mentioned some advantages. I'd like to ask Professor Inouye. Hiro, could you comment on the soft cap? I think it was your idea to destroy this cap and use it for your technique.
Yeah. Yes, that's true. So break it and keep the other side and then fix it. We may use, but in Japan, so such kind of a soft food is available on the market from the one of the company as the name of the top.
In the future, you will be able to buy this hood from a company.
Yeah, that's right.
Okay. So, Professor Yamamoto, I think you're using the Fuji SD hood?
Yes.
So what's the reason for that? Do you use only this hood, or you sometimes change it to another hood?
Most of the time I use the ST hood. That is for pocket creation method. And the reason why I use the ST hood is it is easier to go into the submucosal space because the tip of the hood is only 7 mm in diameter. So easy to go into the submucosal space. And in addition to that, with that tapered hood, we can get a good stable control of the knife. So the selection of the dissection plane can be very precise. So that's the reason why I use the tapered ST hood. And in the submucosal pocket, the outside of the hood touch the submucosa, so it becomes totally transparent. So the endoscopic view is open wide, even with that type of hood. So I like using the ST hood.
Thank you. And Professor Yahagi, Nohisa, you're using quite a simple one, and I had the impression that you said, okay, each cap is good enough, I take this one. Yes, you're always for simple solutions. So what do you see as an advantage of this cap? And can you turn on the microphone once again?
I'm sorry. Yeah, in case of using a standard straight cap, we can get a relatively wider vision throughout the procedure. That is one of the merit. But in case of doing pocket creation method, as Professor Yamamoto already mentioned, and or doing water pressure method, I prefer to use ST hood because of the easiness to go into the submucosal space. And within this underwater condition, we can get a much better view even with the narrowed, a tapered tip because of the magnification effect within the water. So I really prefer to use ST food for all the underwater condition procedure, including water pressure method.
Thank you.
Thank you. So we want to focus on the next point. It's injection solutions, and Alessandro, will you take over?
Yeah, there are many of them already commercially available. I must declare that I love LView, of course, because I worked and mostly invented that all together with the Italian pharma company, with Cosmos. So, but all of them, they are working very well. Normally, it depends on what you're doing. If you're doing dissection or EMR, you may change from one solution to the other solution. What I love from all of them, they are already colored in blue, so they don't need any addiction of vital dye or any dye, and they are ready to go.
So, Alessandro, did you test some other solutions, or you mainly use, or in your routine you use?
In routine, I use LView, but I have working also with ORIs and Lift Up. So in general, my vision is that all of them are working well. There is an issue with all of them, a little bit of creating bubbles under high temperature, especially when they're using coagulation mode. But the way to solve the problem of bubbles is to mix with a little bit of saline, so reduce the bubble creation problem.
And of course, we have to talk about costs. As we know, these solutions are quite expensive. And of course, there are also other solutions, like you can use something like gelafondine.
Yeah, is right. But the evidence we have from at least 2 randomized controlled trials, the LView works much better, and even though you're spending a little bit more in terms of solution cost, you reduce operational time, which is the equivalent in terms of money. So it's a trade-off. It depends on what you're doing.
Maybe Professor Yamamoto, could you give when we were still working with saline solution, we always heard about hyaluronic acid from Japan, and I think you still use that. When do you use which solution?
Yeah, I myself use Mucoap all the time. That is the most that is the best for the mucosal elevation, long-lasting mucosal elevation. And in Japan, we can get reimbursement for the solution, so we don't need to worry about the cost too much. That's the reason why I use Mucoap.
Okay, thank you very much. So going further in our presentation, there was quite some development on traction and lifting devices, and we'd like to show you a video from something new. Here, just on your slide, you see some of the ones you might even know. The one is a Prodigy I from Medtronic. Then there were some publications about some rubber band tool, which you can clip on the other side or the opposite side of the lesion. Of course, there's the simple traction device with dental floss or just some suturing. And we just saw from Stefan the invention of Professor Inouye with the snare and clip technique. So first we want to show you a short video from the simple traction device from Michael Kaminsky, who shows here in the colon lesion which was clipped with a clip line, just with some dental floss, then put some traction from outside and lift up this lesion. And then you can see that you get a nice gap between the mucosa and the muscle in the submucosa area. So quite a simple method you can do with each clip and just with some dental floss, so quite a cheap method. And we'd like to show you another method, which is brand new from Medtronic.
We would like to demonstrate you now another novelty for ESD. This is the Medtronic Prodigy I traction wire. And this system is already available in the United States, and it was approved now in Europe and also in Japan, and we are very happy to demonstrate you this device as one of the first centers. This system consists of a curved wire loop, and the system is made of a sharp memory alloy which always returns to the original curved state. And this is a very interesting concept. The first step is now to fix the wire. Doris is opening now the clip. And now I'm trying to grab mucosa and submucosa. Slowly close. Should. Okay. Doris fired the clip. Now we have fixed the wire. And now I'm taking the second clip.
We have a presentation on different lifting or traction devices from Professor Yamamoto, and we go on in the presentation and show you what his tricks are.
Good evening. I'm Hironori Yamamoto from Jitsu Medical University. I will talk about traction methods in the colon. I use three types of tractions in the colon. One is the natural traction. I will show it in the following video.
Okay, welcome back. I want to show you the progress. This is the pocket I created. As you saw, the lesion was located on the muscle fold, so you have to keep it in your mind. This is the muscle layer. So this is the fold. So you come to the top of the fold. You have to press down the muscle fold to make the approach tangential. So using the ST hood and the pocket creation method, you can get a tangential approach all the time. And
I use pocket creation method in the colon. After creating the submucosal pocket, the endoscope tip is very stable. This is the fold, you see, the muscle fold. And the dissection plane was right above the muscle layer, leaving a little bit of submucosal tissue on the muscle layer. And then I opened the pocket from the left side, but I left a little bit of tissue on this edge, not to lose here, not to lose the tension, okay? A little bit of tissue I left. But when I opened the pocket, the procedure could become unstable. So I used the natural traction. That means traction by gravity and traction by a little bit of submucosal tissue I leave on purpose. And then now I made a circumferential mucosal incision. Okay, then I can approach from here. To cut.
So the last
But
cut.
before cutting here, don't forget to cut the other side, because this is the dependent side of the gravity. So this side should be cut first. Okay? Okay, now only this part hanging with this part. So still I have a good traction. So that's it.
Congratulations.
Thank you. Thank you very much. So by using a good strategy, the traction can be maintained by just natural traction, using gravity and a little bit of submucosal tissue I leave. The next one is a single clip traction. This is the again the pocket creation method. After creation of the submucosal pocket, I used a reopenable clip. In this case, I used a sure clip, grasped the specimen, and then open again and hooked it to the wall on the other side. And just by using this single clip, the traction can be applied effectively. So the amount of traction can be adjusted by the amount of the insufflation. With the good traction, the opening of the pocket is easy, as you can see in this video. Then stable control can be maintained throughout the procedure, and you can finish the ESD like this. The next one is pulley clip elastic line traction. This is very useful for a large lesion in the rectum. You can adjust the length of the clip by just pulling the line. And with the good traction, the opening of the pocket is stable and easy. And even for a large lesion like this, the ESD can be completed successfully like this. So I showed the three types of tractions in the column: natural traction, single clip traction, and pulley clip elastic line traction. I select one of these according to the size of the lesion and the location of the lesion. Thank you for your attention.
Thank you very much, Professor Yamamoto. And one question to Naohisha.
Yeah.
How often
Yes.
how often do you need a traction device, or at least a clip line, for the resections in the colon? Is it like 50% or almost 100%? What is your experience?
For the big rectal lesion, I sometimes use clip and line traction method because we can accelerate the dissection time. But mostly I can finish my procedure without using traction device because I can use water pressure method. Therefore, probably around 10% of all my colorectal ESD cases, I finish with some traction device.
Thank you very much. Alessandro, I know you have also some experience with traction device, and one we didn't mention yet is the Lumen system, which was actually developed as a stabilizer in the colon, but is also used for traction. What are your experience?
So let's go ahead with the stabilizer. So this is a device that's been introduced a couple of years ago, but there are also other systems to keep, especially the colon, very stable into the operating field. You see there is the double balloon or the single balloon technique. There is also this new AGI scope from Fuji, which has a balloon on the tip of the scope, which is very helpful to have the scope stable over therapeutic procedures. Now we want to show the concept of Lumendi. Is an over tube with the two balloons, one front balloon and one rear balloon. The front balloon can be advanced and can contribute, once both of them are inflated, can contribute to create what they call the therapeutic zone. Therapeutic zone stabilizes the colon, the scope, and also the use of any endoscopic devices, and may help in preventing colon slipping, the spasm, and of course the translated much better control of what we're doing during therapeutic procedures. So this is how the system works. Once the two balloons are inflated, you can use air or water or whatever you want, and you create your own therapeutic zone. And at that point you may also consider to advance a little bit more the rear balloon to stay closer to the lesion. But in general, the concept, you are creating a specific therapeutic zone where your movement will be more stable and more controlled. These are two cases that we want to show. One is a recurrent lesion after several attempts of resection into right colon that was very difficult to be approached. And at this point, using this device helped so much in looking beyond the lesion, making proper injection, and elevating and afterwards starting the dissection. We knew from previous histology there was high-grade dysplasia lesion, so the aim of this resection was to have the polyp in a single piece. As you can see in this demonstration, the scope is extremely stable and I'm having very good control of the ivory knife, and at a certain point we also use the front balloon to get some traction of the lesion. This is very important, as has been said before by the Japanese expert. There are part of the procedure where traction can be very helpful to expose the hidden submucosa that otherwise cannot be reached easily even though you are using any kind of cap. So now we are using this concept that we are tractioning nicely the submucosa, even though we are in an area of a lot of fibrosis because of the previous treatment. You can appreciate how much was the fibrosis at that level, even though we're using the water jet, we cannot elevate too much. And again, the control of the movement is very good and very precise, and this can allow you to complete the procedure safely without any pressure. So the other case I want to show you is this big lesion again to the right colon, and this is to show how the inflated front balloon can be used to help in moving the polyp towards the scope and allowing a safer and also much better resection, because the exposure of the area to be resected is much better and more clear using just the stabilization and the balloon that we have inflated the front balloon. So there are a lot of data on this, and this is the latest publication. Huge study, 111 patients. They compared Lumendi assisted procedures versus standard ESD. Even though it was not statistically significant, the authors were able to show there was a trend towards increased and blocking curative resection using the Lumendi technology at the platform zone. So I think now we are moving to the generator.
Okay. Thank you very much, Alessandro. So next setting, we already saw in the ESD videos that you're changing the current of your ICC quite often to different settings.
It's not ICC any longer.
No,
it's Vio now.
And earlier days it was always just the blue or the yellow tipping.
Yeah, you're right.
And now we have a lot of possibilities how to change them. And from the ESD video from today, we have a short
In case of having minor
setting.
bleeding like this, we can easily stop it by applying closed tip of dual knife. In this situation, we usually use spray coag 1.2. This is usually good enough to stop this kind of minor bleeding. I usually switch to very low setting of forced coag, which is 0.3. Forced coag, please. And hook this blood vessel with the open tip of dual knife, then coagulate it until it completely turns to whitish. Now vascular network turns to completely whitish. Swift coag, please. Then we can safely dissect here without having any bleeding.
So I think from that side I got a lot of settings, and for everybody starting with ESD, he's going somewhere for training and taking the settings for the machine home. Now Hisha, how did you get your experience with the knives and also with the changing from the Vio 300 to the Vio 3, and do you still improve these settings, and what do you recommend, and where do we find these settings?
Initially, I just wanted to cut the target tissue, but as a result of cutting too much, it caused lots of bleeding. Then I reduced effect or sometimes maximal power and try and error. Then find the appropriate setting for the safer mucosal incision and safer submucosal dissection. And coming from the Bio 300, I realized that Bio 3 is more precise, and we can cut the tissue more effectively with much less bleeding. But the previous software also reduced the power when we use the forced coag for hemostasis. That's why it didn't work well. Yeah. Then I recognized that for the knife tip coagulation, a spray coag is much better. But now Abe company improved the power of the forced coag. Then probably we can use the same setting of forced coag for the hemostasis in the near future. So it's kind of experience, but depends on the skills of the endoscopist. We can find the best solution depending on the skills of the endoscopist.
Okay, thank you very much. For our EndoSwiss channel, we want to place a setting for the dual knife with the RB Bio 300 and Bio 3, which we developed together with Professor Yahagi. Or he mainly wrote it down for us. And we want to publish this next week then. Professor Inoue, how did you find out about your settings and what do you use for the triangle tip knife?
So, thank you very much. That is a very important question. So, when we the best energy setting when we use TTJ, triangle tip J. So at the time, so spray coagulation 50 watt effect 2, that is a best matching to the device. So it's not necessary to actually contacting to the tissue. So previous Stefan Siebert, so his demonstration of the squamous cell carcinoma ESD. So like that, so it's not necessary to hook the tissue up or coop the pick the tissue up. It's not necessary. Just place the triangle plate close to the tissue, and then using the spray mode, we can dissect the submucosal fibers. So I recommend the spray 50 watt effect too. Even for POEM procedure. So for example, during POEM procedure, most of the case we do not use a coagulospa anymore. So just using the spray coagulation, even for POEM procedure.
Thank you. This brings us directly into bleeding management. If we can change back to the presentation. Also bleeding management, if it starts bleeding, we know we lose our overview and it's difficult to find that lesion if it bleeds too much. And of course, the current settings are very important, but also the management if it bleeds and maybe how to prevent bleeding. Here are some things we want to mention, and also want to show you some new things which were developed for better bleeding or get a control of the bleeding. So this is a short video we'd like to show you.
Okay. Wieder Messer. So the last cut, I hope. Oh, again, bleeding. And you see here the advantage in such a situation, the RDI filter is very helpful. We have less blood, we see the rupture site, and we can very open, quickly close. Place the core grasper at the right place. Open. Okay, that was a very good example how less stressful the bleeding treatment is with this new technology.
Stefan, I have a question. What about the bipolar forceps?
Bipolar forceps is also new development. We know, of course, from surgery, and we'd like to show you another video with that.
Dear colleagues, I'm here with Dr. Yakovenko from Oberik Clinic in Kiev, and our team Esther and Doris, and we would like to demonstrate you some new features with regard to treatment of bleeding during resection. We have here a patient with an early esophageal cancer where we are performing ESD. We would like to show you another novelty. This is the new bipolar coagulation forceps from Pentax company. Bipolar coagulation has a different concept. The current doesn't go through the patient, but only between the two cups of the coagulation forceps. Doors open, please. And we would like to demonstrate this now to you. So the vessel is there. And close a little bit. Yes. And now open a little bit. Close, yeah. Yes. And now we push the forceps into the tissue. There's no risk of deeper tissue damage because, as I mentioned, the current flows between the two cups. And sometimes you can close, but you don't need to close. We can coagulate now. And you see nicely, I didn't close the coag grasper. It was open, and the vessel is nicely coagulated. I think this concept is very interesting, especially for areas where we have a thin wall in the duodenum or in the cecum. In this situation, I would not use the coag grasper at the moment because this is only an oozing. It's not arterial bleeding. And as I mentioned, because of the risk of a delayed perforation, we would prefer to use the new Medtronic Next powder. And here you see Anna has prepared this Next powder, and it is important to switch on the system before you introduce the catheter. Okay, switch on. This is to keep the working channel and the catheter free of fluid. So now I'm in front of the resection area, and now Anna will release powder on the red button. Okay, stop. Stop. Okay, we wait a little moment. Okay, we have more powder, so a little bit more. And with this red button, you can also adapt the amount of powder. Okay, stop. Okay. Okay, so we have covered now the resection area with Next powder. In such a situation where we have only an oozing, I prefer to use Next powder because the first and the second day after the resection, when we have a rebleeding, then we have better conditions using coag grasper than in this moment because the wall is extremely thin. And I think now it looks that we could control this bleeding.
Now you just saw this prevention tool or getting control of very small bleedings in the duodenum, for example, with the Next powder. The coagulation forceps from the Pentax company has a big advantage that the current is only flowing between the two forceps, and you can press it against the wall if you have the vessel inside, and it's only going through the vessel. So I think it's a very nice tool. Do you have experience with it, or you used it?
Yeah, we have experience with the bipolar. We use in all, I would say, tough situation where we scared, and it works nicely. Technique of using is a little bit different as compared with coag grasper. You should not pull. You should stay stationary and wait a little bit longer. So press the pedal for a little bit longer time. But it works as well as the coag grasper without any risk of deeper thermal damage.
So maybe I can ask now, Hisayagi, you have a different approach, I think, for these lesions in the duodenum. I'm not sure whether you use the spray, from which we don't know if it helps at all or for how long it'll help to prevent the bleeding. Maybe you can tell us about your technique if you do a big lesion in the duodenum.
Yeah, unfortunately, that kind of spray powder is not commercially available in our country. Therefore, mostly I try to stop it using monopolar forceps. But if the bipolar forceps is in my hand, I prefer to use bipolar forceps because it works very well even underwater condition. But after complete resection of the tumor, we should completely close that area because exposure to the bile acid and the pancreatic juice can create the secondary complication after the procedure, such as delayed bleeding or delayed perforation. So just hemostasis after the procedure is not good enough to keep the safe condition. Therefore, I completely suture the large defect after the procedure. That's my usual clinical situation.
We have a short video from you where you did this closure technique.
Before showing our actual suturing technique, I would like to show you how to set up string and clip. Now my assistant is preparing Olympus reloadable end clip and surgical suture line. This is a 4-0 blue-colored surgical suture line, and we usually make a small loop like this, and in order to make it sure, we make a second loop and carefully tighten it a little bit, and it becomes small enough to hook it to the metallic part of the end clip, making a knot. Now it's firmly fixed to the end clip, but in order to make it sure, we further make a knot using tweezers. Catch the tail of the string with the tweezers, we can easily make a third knot. After cutting the tail, it's ready to use. This is resection bed. As you can see now, there is no muscle injury at all, and I already coagulated exposed blood vessel. And as you can see here, we can see the movement of the outside through the muscle layer. That means muscle layer of the duodenum is quite thin. Therefore, it's mandatory to close every large defect after ESD procedure in the duodenum to avoid serious complications such as delayed bleeding and perforation. Now I'm going to close this large defect using string clip suturing method, which I originally developed a few years ago. Okay, open it please. Now I introduced clip and line. My assistant, Mr. Sasaki, already make a knot on the metallic tip of the Olympus reloadable end clip. Okay. And hooking the line to my fifth finger and approach to the inner side. And it is very important to capture both mucosal edge and part of the muscle layer together. Otherwise, it becomes very superficial suturing. Okay? I intentionally captured part of the muscle layer and suck the air to make the muscle layer relax, and slowly close the end clip. Okay. Now first clip is deployed and anchored at the inner side. Then introduce the second end clip and catch the line with the tip of the metallic clip and anchor it at the oral side. And again, it is mandatory to capture the part of the muscle layer and surrounding mucosa together and suck air and close very carefully. Okay. Now string is anchored on both anal and oral side. Now I'm introducing third end clip, which is large-sized Olympus reloadable end clip. Okay, open. And open it carefully, just beside the previous end clip. And catch the mucosal edge at the oral side. And gently pull the string and suck air a little bit and fire it. Okay. Now inner edge is completely closed, and prepare a fourth end clip. I'm going to approach at the right side, then catch the mucosal edge and rotate the end clip a little bit. Okay, that's perfect. And again, pull back string a little bit and suck air. Okay, fire. Okay, that's perfect. Now the large defect almost closed. This is Olympus scissor. By hooking the string and push forward, then cut it. Okay. I would like to give additional end clip to close the defect completely. This is the final result of my procedure. The large defect was completely closed.
Thank you very much. Very, very impressive.
Yeah, thank you very much.
So thanks for that. And Alessandro, from your side?
Yeah, also very thankful to everybody who followed this session. Very interesting. I learned a lot from Japanese masters. I want to thank them personally. Also, Stefan, thank you so much for leading this session. It's been great.